So today's topic, as I mentioned, is understanding ctDNA. It's a new tool for bladder cancer care. And why is it so important? It's a simple blood test that looks for traces of DNA in your bloodstream. And now we're going to hear about why it's becoming really important for patients with bladder cancer. Dr. Bellmunt has been a friend of Beacon for many, many years. And I don't know that this was even on your radar 20 years ago when Beacon got started, was it, Dr. Bellmunt?
Yeah, no, absolutely. We were discussing. I joined the first meetings at Beacon long ago when we didn't have any white hair yet. So here we are.
Right. Yeah, which is just amazing. So much has happened in the last 20 years. So this just can help detect cancer earlier. It can show whether your cancer treatment is working, maybe even spot signs of recurrence. For patients with muscle-invasive or advanced bladder cancer, knowing your ctDNA can really help them decide on more specific treatment options for them and more personalized treatment and maybe a greater peace of mind because you're doing everything you need to do for your particular tumor type. So we are really delighted to have Dr. Joaquín Bellmunt here. He's an associate professor at Harvard Medical School and director of the Bladder Cancer Center at the Dana-Farber Cancer Institute in Boston. Dr. Bellmunt will explain how ctDNA works and why staying informed about this new tool can really make a difference in your care. Professor Bellmunt is also a senior researcher at the Institute Hospital de Mar Investigaciones. I'm not going to say this. Can you say it, Dr. Bellmunt?
Yeah, so this is from I still have my lab in Barcelona at IMIM Hospital del Mar. Yeah.
Great. So you really do pop back and forth and are very engaged in global bladder cancer care. As a urinary medical oncologist, you practice as a principal investigator in so many clinical trials, and we really appreciate your time and sharing your expertise. I'm going to turn the screen over to you. If you want to share your slides now, you're welcome to do that.
Yeah, so.
And I'm going to turn off my camera and I'll be in the background and we'll get to questions and answers at the end of today's program.
All right, excellent. Thanks, Stephanie, for the kind introduction. And as mentioned, it's a pleasure to be here on these 20 years of impact of Beacon. As mentioned, I joined the first think tank meetings like almost 15, 17 years ago. And I have been involved and collaborating. So that's a great effort. And I want to thank Stephanie, Allison, Patricia for making this lecture to happen, despite I canceled because of some unexpected commitments. So I'm going to explain you a bit what's the present status of the ctDNA as a new tool for bladder cancer care. So some of the things that I'm going to explain that are listed here, likely some are not fully accomplished. So, but we are trying just to learn a bit what ctDNA is and how it can help find cancer. That's one aim. Also, how it can help doctors choose or change treatment. Still, we are not there, but we are getting there. How it may show if cancer comes back before even the scans can show that, and how it helps patients feel more in control of their care. So those are the main aims. As mentioned, we are heading there. So we still are not fully accomplished all these aims. So first, I'm going to introduce several terms just to make clear what we're talking about. So the first term is the liquid biopsy. Liquid biopsy is a biopsy, but instead of getting tissue, we are getting blood, and we are trying to analyze the blood if there are cells there. So, and the first documented evidence of a solid tumor material in peripheral blood is coming from this paper, that is 1869 in Australia, where this was a patient that died, and then in the blood, they were able to capture cancer cells. So this is the first documented paper or experiment just showing that the tumor is like spreading and circulating in the blood. And then going back again to the term liquid biopsy. Liquid biopsy is a wide term. And in the liquid biopsy, meaning doing a biopsy in the blood, we can find different components. And you can see here in this cartoon in the right side, you can look for ctDNA or cell-free DNA, and we will talk about what's the difference between cell-free it's cfDNA or ctDNA. That's very important. Is that I have underlined the T and the F. But you can look for circulating tumor cells. You can look for extravesicles, proteins. So many things in under the concept of liquid biopsy. So what we're going to talk about is the cell-free DNA in the blood plasma. And this is a very easy to obtain research. And there we can capture the cell-free DNA and the cell tumor DNA, the ctDNA. So three concepts here: cell-free DNA, circulating tumor DNA, and this is completely distinct from what we have heard on circulating tumor DNAs. And I could say that cell-free DNA is like whatever DNA is floating around is named cfDNA, and the one that is tumor-specific, and we have tools to identify that this DNA, because of mutations and copy numbers, is a tumor DNA, and then we have these CTCs. So we are going to focus on the concept of cell-free DNA. Cell-free DNA, that's the first thing, meaning is DNA that is found in the blood. And this is mainly coming when the cells die. They are going through what we call apoptosis. The DNA inside the cells are shed into the blood. And we know that the normal cells die too. So when the majority of the cell-free DNA that is found in the blood is coming from normal hematologic precursors. And usually we see fragments of 167 base pair. So very, very, very tiny fragments. And the amount of DNA that is found, of cell-free DNA that is found in the blood, is between 5-10 nanograms per ml of plasma, meaning that is very, very tiny amounts that we are now having technologies that are able to capture this DNA that is floating, isolated, this specific CT, circulating tumor DNA, and obtain results and provide guidance. So another thing is that there are the ctDNA, circulating tumor DNA. There are different tests now are commercially available. And obviously, all the time that we are talking about ctDNA, the first thing that we need to ask is, which test are you going to use to monitor my ctDNA? And there are tests that are mainly focusing on detecting tumor, detecting cancer. But there are other ones that are, in fact, going not further, in a different way. They are characterizing which type of cancer cells are there. So this is completely two different concepts. And obviously, the techniques are improving, and we know all the companies that are investigating on that, they are increasing on sensitivity and specificity, but still, as of now, still we are a bit suboptimal. So those are not 100% sensitive and not 100% specific. There are new evolving techniques that I'm not going to present, that epigenomic techniques that are emerging, trying to better characterize the cell, the ctDNA floating in our blood. So three main groups of areas on how the CT, the circulating tumor DNA test, might help managing cancer. The first is that we can improve cancer screening. And we know this paper in the right, in patients that this predisposing cancer syndrome leave from many, cell-free DNA was used to identify early appearance of cancer. And also, we are presently using for a concept that is named minimal residual disease. And minimal residual disease is a concept coming from hematological malignancies, leukemias, that there were tests that we were able to detect very tiny amounts of translocations, for example, in chronic myeloid leukemia. So this is also now being done in solid tumors like bladder cancer. That's the first group. The second group, we can use ctDNA as a way to monitor the response to therapy. As you can see in the paper in the right, plasma ctDNA as a treatment response biomarker in metastatic cancers, correlation with the RECIST criteria, the classical radiological criteria. And also, we can estimate how aggressive is a cancer, a tumor. So in the right, you can see here this paper from Nature Communications 2021 in unselected first-line metastatic urothelial cancers, patients having low ctDNA. All these patients were doing much better than patients having high ctDNA. The third group of concepts that we where we can use the ctDNA is predicting treatment efficacy, also identifying resistant mechanisms. And now this is being used, for example, in tumors like lung cancer, that we have drugs that are under treatment. The tumors change their phase and they create new mutations. And through monitoring the blood, we are able to say, well, this treatment is no longer responding. Then we capture the changes that the tumor has developed, and then we implement a new therapy for this resistance. So we can characterize the biology and the evolution. So a lot of areas where ctDNA is helping on making decisions, assessing the prognosis, and establishing the best treatment for patients. As mentioned, the ctDNA test is not that one size fits all. And we mentioned that. So there are tests that are going to help us to detect cancer, and it's not going to provide, in general, any additional information. Say, well, you have malignant cells in your blood, or there are others that are like characterizing more specifically the type of mutations or the type of genomic alterations that this tumor is having. So focusing on detecting, and detecting is a way to say, well, I want to make sure that this tumor is in complete remission, and you want to make sure that there is no minimal residual disease. For that, there are two different types of platforms. One is what is called the Tumor-informed. This is a customized is a bespoke platform where we create a personal, the company who's doing that is creating a personal test to follow this patient. That's an example of the Natera Signatera platform. So this is a specific test. Obviously, you need to, and we're going to discuss more about this platform that is widely used in bladder cancer. And then there are different platforms that are tumor naive. So meaning those are not platforms that are personalized. So this is like, we know that in bladder cancer, there are specific genomic alterations that are well known based on the TCGA work and so on. And we create platforms to look for specific mutations or genomic alterations that we know are highly prevalent in bladder cancer. And this is using the same test for all the patients. That's different, the tumor naive to the tumor-informed, where we are using a very highly personalized approach to monitor the minimal residual disease. Now, as mentioned, minimal residual disease is very important. We're going to discuss its role, for example, in the follow-up after surgery in patients with muscle-invasive bladder cancer. So let's go back a bit when several emerging studies did show the benefit of using the ctDNA. So you can see here ctDNA detection after surgery, indicating what we call the molecular disease progression. And this is seen before you see a clinical relapse, meaning until the radiographic images are coming positive. And these are publications from 2017, 2018. We can see here that in lung patients that the ctDNA was negative, no cells found after surgery. The relapse-free survival was higher than patients having ctDNA positive, meaning DNA material from the tumor floating in the blood. The same for bladder, the same for colorectal cancer. So this is not only applicable to bladder, but as you can see, to so many different tumor types. Also, we mentioned that before, and this is coming from a phase 2 study of pembrolizumab in advanced solid tumors. It was shown that low baseline ctDNA levels are associated with better survival and progression-free survival. Is a way to monitor the tumor burden. So if you have less cells in your blood, your outcome is going to be much better. And obviously, if this is like decreased by the treatment, and this is something that we see in here, this is the same study. In these initial studies, as mentioned, this was published in 2020, we can see that patients receiving pembrolizumab, if there was a reduction of the amount of circulating tumor DNA in the blood, those patients were doing much better. So it's a way to predict, monitor if the patient is responding well or not responding well under treatment. And this case is for immunotherapy.